Right, now let's talk antibiotics. And antibiotics, they fall under this category of antimicrobial medication. So we've got our antibacterials, which we'll talk about here in this session. We also have antifungals, antivirals, and antiparasitics. So all of these antidrugs fall under the broad category of antimicrobials. And then when talking about antibiotics, we have to pay attention to the types of bacteria that we are targeting. We've got gram-positive bacteria, we've got gram-negative bacteria. Our gram-positives have a thick cell wall with no outer membrane, and our gram-negatives do have an outer membrane. So here's our gram-negatives. They've got a this cell wall here, and we've got this outer membrane on our gram-positive sign, right? That cell wall is it's still there, but it's much thicker than the gram-negatives. So if we give an antibiotic that goes after the outer membrane, that's not going to do anything for a gram-positive bacterium. So we do have to pay attention whether the bacterium we're going after is gram-positive or gram-negative. And that's all important because our antibiotics work in a few different ways, and different antibiotics work in different ways. We've got antibiotics that are cell wall inhibitors, go after the cell wall. We've got antibiotics that are cell membrane inhibitors and go after the cell membrane. But remember, if we've got a gram-positive bacterium and we give this cell membrane inhibitor, well, that's not going to do anything to that bacterium now, is it? And then we've got protein inhibitors, and we have DNA inhibitors. So first, what we're gonna go through these one at a time, and first we're gonna focus on our cell wall inhibitors. And looking at this box right here, you might already recognize a couple of these. We see vancomycin, we see bacitracin, we see penicillin. These are some cell wall synthesis inhibitors, and the big category here are our beta-lactam antibiotics. So these are our penicillins and cephalosporins and monobactams and carbapenems. Getting into the actual medications, we've got penicillins, but we have amoxicillin, we've got vancomycin, and bacitracin. And these are very, very popular, very commonly prescribed antibiotics. So our beta-lactam antibiotics, they inhibit the synthesis of cell walls. So we can't rebuild cell walls as they break down. And beta-lactams are bactericidal, so they do go in and kill bacteria. Penicillin is the big one here in our beta-lactams. We've got a narrow spectrum penicillin, typically abbreviated as PCN. So our penicillin G and penicillin V are what we typically call penicillin, kind of our original penicillin. It is very narrow spectrum. And then we can go into our extended spectrum penicillins. That's when you start seeing amoxicillin and ampicillin, which are very commonly prescribed as well. I'm sure you've seen amoxicillin out there. And we also have a few penicillinase resistant medications that have been developed. So as we get into penicillin resistant bacteria, what they do is these bacteria produce penicillinase, which breaks down penicillin. So then we have developed in turn penicillinase resistant penicillin. So antibiotics that are resistant to this thing that the bacteria produce that break down the antibiotic itself and make the bacteria resistant to the penicillin. Similar to that penicillinase is beta-lactamase, and so bacteria that are resistant to these medications, like amoxicillin or penicillin, can also produce beta-lactamase, which breaks down that antibiotic and makes it non-functional. So we've developed beta-lactamase inhibitors. So we give a type of penicillin in conjunction with one of these beta-lactamase inhibitors. Takes out the beta-lactamase and allows the antibiotic to do its job. So It's a penicillin type beta lactam type antibiotic plus a beta lactamase inhibitor. So these are combination drugs. So we see amoxicillin plus this beta lactamase inhibitor, we get augmentin. We've got this plus or piperacillin plus this beta lactamase inhibitor, we get zosyn. So if you see augmentin, if you see zosyn, that is a beta lactam antibiotic, which is a cell wall inhibitor, plus a beta lactamase inhibitor, and our augmentin and our zosyn, pretty common out there. Those are our combination antibiotics. Then we've got cephalosporins. These are still beta lactam antibiotics, just similar to penicillin, just a little bit different. But we've got different generations of them. The first generation, you'll see Ancef, you'll see Keflex. They're pretty popular out there, or fairly common, I should say. As we get into subsequent generations, the second, third, fourth, they get broader in spectrum, which is really important. So our Ancef, our Keflex, a little bit narrower in spectrum than our later ones, like Rocephin. You'll see Rocephin, especially in the hospital, being given. And as we get to those fourth generation cephalosporins, there is a much larger resistance to beta lactamase. Well, now why would a physician, PA, NP, prescribe penicillin versus one of these cephalosporins? Well, pretty similar mechanism of action. Both are bactericidal, both are going to kill these bacteria. Very similar in chemical structure, but cephalosporins are much more stable than penicillins and don't have or don't run the risk or as high a risk of allergic reactions. A lot of people are allergic to penicillin and penicillins. So if we can give a cephalosporin, that decreases the risk of allergic reaction. Our other two kind of broader categories are beta lactam antibiotics are monobactams and carbapenems, and really what we want you to be familiar with, at least here, monobactams are for gram-negative bacteria. Carbapenems can affect gram-negative bacteria, but also are used for gram-positive bacteria. Now moving on from our beta-lactam cell wall synthesis inhibitors, let's talk really briefly about vancomycin. Vancomycin is another common antibiotic out there. It's still affecting the cell wall, so it's blocking new subunits of cell wall so that the cell wall can't regenerate itself as old cell wall subunits kind of die off. So we're breaking up the cell wall, going after the cell wall here. Vancomycin is used for gram-positive bacteria and is typically the first line, first go-to antibiotic for MRSA, methicillin-resistant Staphylococcus aureus. So this essentially penicillin-resistant bacterial infection. Then a few minutes ago, we also mentioned bacitracin. Bacitracin is used for gram-positive bacteria as well, but bacitracin is nephrotoxic and is not given IV, not given systemically. So we're going to see bacitracin given topically for topical skin infections. Okay, so those were our cell wall synthesis inhibitors. We had vancomycin, bacitracin, penicillins, all our cephalosporins and monobactams and carbapenems. Now we're going to move over to our protein synthesis inhibitors, still antibiotics. Just going after, instead of the cell wall, we're going after specific proteins, our 50S and our 30S proteins. And these proteins are required for bacterial synthesis. So for the bacterium to replicate and keep itself going, the bacterium needs these proteins. So if we can block these proteins, we can block bacterium synthesis and replication. So we've got 30S antibiotics, we've got 50S. So the 30S proteins, the 50S proteins, we can block either of these. So we've got tetracyclines in our 30S. I'm sure you've heard of some cyclines and aminoglycosides, and we've got macrolides that block the bacterial 50S proteins. So with our 30S proteins, we have aminoglycosides. The big one in this category is gentamicin. It is a narrow spectrum antibiotic, and it binds to these 30S proteins and doesn't allow for bacterial synthesis and bacterial replication. So aminoglycosides going after 30S proteins, and gentamicin is our kind of prototypical aminoglycoside. Also going after 30S proteins are our tetracyclines and well, tetracycline and doxycycline. So if it ends in cycline, you know it's a tetracycline. If you see the medication tetracycline, I hope that you know that it's a tetracycline antibiotic. These are bacteriostatic. They're not bactericidal. They're bacteriostatic. They stop the growth of the proteins or of the bacteria, excuse me. But they are binding still to the 30S protein within these bacteria. Then we have our macrolides. Moving on from the 30S, we go to the 50S proteins. So these are binding to 50S proteins, and this is when we get into our Z-Paks, right? So if you've ever gone to your doctor, to the health center, and they think you might have a little bit of a sinus infection, they give you a Z-Pak. This is Zithromax, zithromycin. The Z-Pak, that's a macrolide, is a protein synthesis inhibitor. If you want to go a little bit further, there's also clindamycin and erythromycin. These are most commonly prescribed for respiratory infections, pneumonias, upper respiratory infections. So if you go in and they say, you might have a little sinus infection, you might have a little respiratory infection as a result of whatever it is, they give you a Z-Pak. Your Z-Pak, that's a macrolide, and that is going after the 50S protein within those bacteria. So there we just covered our protein synthesis inhibitors, our 50S and our 30S proteins. We've talked about cell wall synthesis inhibitors. Now we're going to move on to metabolic inhibitors, and more specifically folic acid metabolic inhibitors. Again, all antibiotics, all going in to inhibit and or kill bacteria. And we're just moving on. We talked about cell wall. We can go after the cell wall. We can go after these proteins, or we can go after metabolic processes. The key drug here we want you to focus on is Bactrim. Bactrim is an antifolate drug that, well, it's antifolate. It inhibits folate, and folate is required for DNA replication within the bacterium. So without folate, it can't replicate, it can't grow, it can't spread, it can't go anywhere. And Bactrim is commonly prescribed for urinary tract infections. All right, let's round this out here. So we've talked about cell wall synthesis inhibitor, antibiotics, we've talked about protein synthesis inhibitor, antibiotics, we've talked about metabolic inhibitor, antibiotics. Now let's talk about DNA inhibitor antibiotics. So we can give medications that go directly after the bacterial DNA and the replication cycle. And within these DNA inhibitor antibiotics, we want you to know about fluoroquinolones, which is a really fun word to say. So fluoroquinolones are inhibiting bacterial DNA replication. So bacteria cannot replicate, cannot grow, cannot spread. They are bactericidal. So you kill off DNA, you kill off the bacterium. These fluoroquinolones are very broad spectrum. They go after gram-positive, they go after gram-negative, they go after bacteria. So you take one of these antibiotics, we all know about our kind of endogenous and internal good and bad bacteria, and we've got good bacteria in our bodies. These antibiotics go after everything, and they will clean you out and kill everything. So these are very broad spectrum. They go after gram-positive and gram-negative bacteria. And the most common in here, or maybe most common, Cipro and Levaquin. So if you've ever been on Cipro, if you've ever been on Levaquin for an infection, if you know someone who's been on Cipro or Levaquin for an infection, you know that these are broad spectrum and they've got some kind of gnarly side effects because they are killing off our good bacteria, especially within our GI system. But these medications commonly prescribed for UTIs, urinary tract infections, and pneumonia and kind of deeper respiratory tract infections. All right, one last thing to cover broadly in this kind of really big kind of top down big overview of antibiotics is tuberculosis caused by this tuberculosis bacterium, most commonly affecting our lungs. So the treatment of tuberculosis and active tuberculosis is long and it involves multiple medications. So 6 to 9 months for treatment of a tuberculosis infection. You're going to be taking a number of medications in conjunction with one another, and the goal is to completely eradicate all that bacteria, all those tuberculosis bacteria. Because if we do a chest x ray, this pops up and that just doesn't look good, right? So we want to eradicate that organism. It's going to take a while and it's going to take a number of drugs. Just one medication isn't going to do it, and it's going to be a number of medications. And just like all the other antibiotics we've been talking about, we can give antibiotics here for tuberculosis. They're very specific to this bacterium, but go after different parts of the bacterium. So we can inhibit mycolic acid, we can inhibit RNA synthesis, we can inhibit cell wall synthesis, we can go after cellular pH. And one drug in particular isn't really going to do the complete job that we need it to do. So, like we mentioned, this is going to take 6 to 9 months. Kind of give or take, depending on the patient. And it's going to take a number of drugs. So we're going to do a couple in combination. We might do a few in combination. Might start with INH and then go to rifampin. We might start with one, go to another. We might pair up a couple, go back to one, and then go to another. So multi-drug therapy here, and a multi-pronged attack on this bacterium. And as always, if you have any comments, questions, concerns, cuss words, please let us know.